כל, מרק, תודה על ההזמנה, ואני אדבר באנגלית בגלל שיש לנו הרבה אורחים שלא מבינים עברית, אבל האמת היא שאני מעדיף בישראל לדבר בעברית, לתת הרצאות בעברית, אבל במקרה הזה אני אעבור לאנגלית. Okay. It's because Christoph doesn't speak Hebrew. Not you, Rob. So this is a very boring talk because it has no pictures of nails. It's no pictures of cases. It's data. Ugh, how boring. But it's actually very revealing about a few things. Now, it represents our retrospective experience from December 2011, which is the first precise nail inserted in the United States, December 1st, 2011, until November 2016, 355 patients and 568 nails. There were 215 males, 140 females. The average age was 22.6, but the youngest was 6 years old, that's most notable, and the oldest was 69. 126 were bilateral, obviously stature-type lengthenings, and 229 were unilateral. 87 were multi-segment simultaneous lengthenings, either unilateral or bilateral. So it could be femur tibia unilateral or two tibias, two femurs. Sometimes it was two femurs, two tibias, all simultaneous, four-segment lengthenings. It's interesting when we look at which way we put the nail in, we had the majority, 411 out of 568, were femoral antegrade nail. So that's the workhorse. That's still, to me, the number one indication. Femoral retrograde was only 21. I know you saw one yesterday. I actually avoid femoral retrograde because of one particular reason, is that more than 3 centimeter lengthenings in femoral retrograde, you start having more difficulty with the knee rehabilitation and the recovery and maintenance of knee motion. So my personal bias is to do femoral antegrade whenever possible. In fact, I'm going to talk later that even when I'm correcting deformity, as you did yesterday, I would rather put a plate distally and lengthen proximally. I think there's actually a lower risk, lower complication rate, definitely lower knee stiffness. But that's my bias. There's, like Christoph said, there's more than one way to skin a cat. Tibial antegrade was 104, so that's the second most common lengthening. And interestingly, tibial retrograde, I'll show an example of that. That is for ankle fusions. So when you're going to fuse an ankle, it's a tibial retrograde, just like you would do a retrograde nail. Obviously goes through the subtalar region as well. Fibula retrograde was a tibial hemimelia case that was lengthened through the fibula. Humerus antegrade was 10, and even one humerus retrograde with a patient with an elbow fusion in one. So a wide variety. We really, everything except for the forearm was nailed antegrade and retrograde in every bone. We have a bias at our center because we do a lot of congenitals, and so you can see that our largest indication was 152 congenital lengthenings, 72 developmental, 37 post-traumatic, and 94 were stature lengthening either for cosmetic or for achondroplasia. So I'm sure if Rob Rosberg showed this, he'd have a completely different group because he sees more post-traumatic and so on. I see more pediatric, and so I have different indications. And this influences the complication rate quite significantly. So we looked at one interesting thing is, did we achieve the goal of lengthening? And we really did. If we ever stopped lengthening, it was not because the nail couldn't lengthen. The exception was in the P1s, very early generation. There were some mechanical issues that prevented completing lengthening. But in the current nail, that's not the issue. The distraction rate, I want to emphasize this. So when we lengthened with an external fixator, when you would do a millimeter lengthening, you didn't get a millimeter. You usually had some bending of the pins, what we call pin drag. And so I think that actually protected us. And I think the idea that lengthening a millimeter a day is the standard was because we had a stress-relieving valve in the fixator. And that was probably a good thing. When we started going a millimeter a day with the nail, we started getting into lots of trouble because 1 millimeter equals 1 millimeter. So I can tell you, for certain diagnoses, we'll do a millimeter a day. But for most, we'll do 3/4 millimeter a day. And that's a safer rate. So all tibias, I never go more than 3/4. Now, one more thing. When you see good regenerate, when you have an external fixator, what do? It's going to prematurely consolidate. I'm going to speed it up. When you see good regenerate with the precise, great. Don't get excited. Don't speed it up. They don't prematurely consolidate. The one thing about the precise nail, it's over-engineered as far as strength, and with the P2.2, which is the current nail, it has the ability to lengthen against tremendous resistance. So I don't speed up the nails. I don't get excited. I don't think, oh, it's going to prematurely consolidate. You get into trouble with the soft tissues when you go faster. So I don't go over a millimeter a day. I haven't gone over a millimeter a day in a long, long time. I might go up from 0.75 to a millimeter, but I don't exceed that, okay? So I think that's a great advantage of this nail. It's very powerful. Now, a lot of complications on this. You know, a lot of the nail breakages and fatigue were from P1 and P2.0. There were some design features that were not optimal. First nail had welds. You don't have that anymore. Most of you are lucky if you're starting with this, you're dealing with the P2.2, which is a much stronger nail. So the P1 had a high fracture rate, especially in bilaterals where they couldn't follow all the weight-bearing instructions. Somebody asked about weight-bearing. What do? At our clinic, our rule is for 8.5 and 10.7 nails, okay, we allow up to 25 kilos of weight bearing, okay? For 12.5 nails, we allow up to about 32 kilos of weight bearing, okay? So, I'm sorry, no, 35 kilos of weight bearing. 35 kilos of weight bearing. So 25, 35 kilos of weight bearing. The 12.5, you can weight bear more, okay? And especially for bilaterals, it's very important to follow that. All of this is about to become completely unimportant because sometime this summer, we hope to come out with a new nail that's full weight bearing, no crutches. And you'll see that probably, you won't see it for at least another year, but that may be as early as this summer. It's a different material, different diameters, so it's a stronger nail. The company made the nail out of titanium, which in my opinion, from day one was a mistake. They copied the ISKD, and they just repeated the mistake. If they'd made it out of stainless steel, it already would have been stronger. And weight bearing is important, and patients hate, especially bilaterals, being on crutches or walkers for a long time. Okay, I talked about premature consolidation, which is the second thing, which really, all of these premature consolidations were from the P1s, pretty much. Operator error, I'm not sure what that was referring to. Since I did all these cases, I can't believe I made any errors. The nail failed to distract. Again, these were in the P1, the mechanisms. So you can see this was a real problem in the beginning. And what happened in the evolution of this nail is that we do so many nails at our center. that other centers said, we're not seeing these problems, but they were doing 1/10 of our volume. You actually needed to increase the volume to a point that you did this enough that you ended up with uncommon complications occurring. And so we do a lot of this, and you can see these things surfaced. We also apply this to all the indications, from heavy people to light people, unilateral to bilateral, femur to tibia, etc. I want to go down to, we had some fractures through screw holes, and one of the things we've learned is never put an anterior-posterior screw hole in the femur. The tibia, it's fine. Don't put an anterior-posterior screw hole through the femur. You will get some patients who will fracture through that. So lateral to medial screw holes are fine. Do not put the nail comes with 3 holes. Don't lock the anterior one in a femur. I'm going to come back to this, deep infections, most interesting of the complications. Failure of the regenerate with bone grafting. This was only in tibial cases and in infected cases. So tibial and infected. Non-infected, non-tibial, we've never had to bone graft one. Hematoma evacuation, we had 3. Soft tissue contractures and releases, we had a handful, as you can see. Compartment syndrome. So I think this is being overcalled. We've never had a frank compartment syndrome, but we did 3 fasciotomies intraoperatively because by the end of the surgery, it swelled up, so we've never actually had compartment syndrome. We did operate on one person who came to us from a previous center who had a compartment syndrome. So I've never had a true compartment syndrome post-operatively. Deep vein thrombosis, we had only 1. And joint subluxation, because we treat a lot of congenitals, we had both hips and knees. Nerve palsy, we had 16 developed perineal nerve issues, and we had to decompress them. And nail broken at the time of removal, we had quite a few. And especially with the P1 and the P2.0, there were lots of nails that came out in 2 pieces or with multiple pieces. We had patients put the ERC on incorrectly and not lengthen, and that was a cause of premature consolidation. If you don't put the ERC device on, you don't lengthen. We had 2 ERCs not functioning, and we had a bunch of non-compliance leading to various complications, especially premature consolidation. So some of these are duplicate complications here. They're the same complication. So I'm going to skip these and go to the most interesting findings of this study. So the most interesting findings of this study related to infection. So this should be an elective procedure with a very low infection rate because it's minimally invasive. And yet, when we look at our results, we had 21 deep infections out of 568 cases. That is 3.7%. It's much higher than you would expect, okay? And so why is that? So when we looked at this, and we had experience with this with the ISKD, and we had the same experience. We noticed that patients who had previous external fixation or patients with a history of previous infection were higher risk for getting an infection with intermedullary nailing. So 4 out of the 21 did not have a previous X-fix, but 3 of those 4 had a previous history of bone infection. The others, 17 out of 21, had a previous external fixator. Now, why should that be important? When you have an external fixator, you introduce the outside world to the inside world, and you get contamination. I'm not saying infection, but you get contamination of the medullary canal and of the bone. Presumably, some bacteria go into some latent state, L-form state, and remain in the bone. only to be reawoken as a sleeper bacteria later on. And reawoken by what? By sticking a reamer down the bone, devascularizing the canal as every reamer does. Every time you put a reamer down the bone, you know, for intermediary nailing, Rhinelander showed this, I think, in the 1950s or something, that you devascularize the inner 2/3 of the bone for 10 to 14 days. It takes 10 to 14 days for that to recover. I think during those 10 to 14 days, the absence of circulation, the hypovascular state, increases the risk of these latent forms taking root. And I think that's what's happening. Now, we looked at this, and the infected cases, 13 were congenital, 4 were developmental, 2 were post-traumatic, 2 dysplastics, achondroplasia. Most of them were femoral antegrade. Only one there were a handful of tibial antegrades, and that was pretty much it, but almost all femoral antegrade. Now, I know these are busy slides, not really important. Here's the important thing. So, how many of our cases had a previous X-fix? Of the 568 limb segments, 145 of those limb segments had had a previous X-fix. So that's 25.5% of all our cases had had a previous X-fix. Why have so many of our patients have a previous X-fix? Because they're multi-stage lengthenings. You know, they'd had an X-fix, and now next time around, they're bigger, they're older, we're able to insert a nail, and we say, oh, we have a better way to lengthen, less pain, less problem. We're going to put this in, and they get infected. But 145, 25.5%, had a previous X-fix. So if we just take the 17 cases that were infected after previous X-fix, divided by 145, we have an incidence of 11.7%. Now, that's needs to be broken down a little more. So we noticed this was happening. And I got the impression that the incidence was even higher than 11%. So I changed our protocol to try and prevent infection. I started giving intraoperative, anyone with previous X-fix, always vancomycin, because most of the infections were MRSA. The second thing is, I started giving post-operative 2 weeks of oral antibiotics, usually Bactrim, because it covered MRSA, or clindamycin. So we gave prophylactic treatment for 2 weeks to cover that hypovascular time when the medullary canal has a lower vascularity and it's regrowing its vascularity, to give it a chance to recover. And even though this is retrospective, this was quite significant statistically. So we had 79 cases did not get the antibiotic protocol, but they'd had a previous X-fix. And 66 cases got the new antibiotic protocol who had had a previous X-fix. There were 13 infections out of 79, 16.4%, if you didn't get the previous antibiotic protocol. So I was right, our incidence was higher than 11%. And in fact, John, I remember you and I talking about this, and you said your incidence was 5%. I don't know if that's based on hard numbers or an impression. Maybe you guys are better surgeons, and I should clean up our operating room, but somehow we got 16.4% incidence in previous X-fix patients not treated with anything but Ancef usually for 1 or 2 days. And when we went to prophylactic antibiotics, it dropped to 4 out of 66 or 6.1%. That's a huge drop, and that was a very significant, statistically very significant. So all of a sudden, we actually, first of all, we recognized the at-risk group. I think that's very important. But the second thing is, we have a way not to eliminate this risk, but to reduce it from 16% to 6%. That's a very significant reduction. So the message I would leave you is that recognize the two groups that are at high risk, and the two groups are the previously infected cases and the previously ex-fix cases. And I think you have to have a serious discussion with those patients that you have a very high risk, especially the ex-fix cases, that you are at very high risk of, or at a higher risk, not very high risk, but that we can do something, but you have a 6% risk. Now, I want to end with, so what do you do if you get this infection? Okay? So now we know a little bit about the statistics, the demographics of this, and I'm going to skip for time's sake the next part of my talk, which was which groups, the congenitals have the highest complications in general, of all complications. But I want to skip to the end, which is, what do you do if you get an infection? So this girl had a previous ex-fix, 4-segment lengthening, and we then, and by the way, a lot of these patients, almost all of them, got rods in their femurs, and we have very low infection rate, about 4% in rodding on the day of ex-fix removal. And then she didn't have any infections. And then years later, actually several years later, at least 3. And by the way, some of these infections after ex-fix are 10 years later. So it doesn't seem that the time interval matters. We put in bilateral femur nails. And then shortly after, we put in bilateral tibial nails. By the way, now when I do 4 segments, 3 weeks apart, I always put the tibias first. Do you know why? Because to put tibial nails, you need to hyperflex the knee. If you start lengthening the femur, you lose the ability to hyperflex sometimes because you can't bend quite as far. So put the tibia first, 3 weeks later put the femur. But in this case, we did the femurs first, put the tibia, and then shortly after, she developed an infection in this left femur. So what do? If there is pus, you have to let it out and wash it out. Okay? So we make an incision, wash out the wound. If there's no pus, just start on antibiotics. Of course, if there's pus, you also use antibiotics. So we suppress the infection. Do we stop the lengthening? How many of you would stop the lengthening? Raise your hand. Okay? How many would continue lengthening in the face of infection? What do you base that on? So the answer is you can continue the lengthening if you suppress the infection. So we treat the infection, incise and drain it. Where does it drain? It drains either at the distal or proximal locking screws, either at the proximal entrance hole for the nail, or the osteotomy site. Those are all the sites it drains. It doesn't drain at some new site, okay? Any of the sites except for the regenerate site, not a big deal. You incise and drain it, wash it out. The problem if it drains through the regenerate site, it probably has damaged some of the regenerate bone, at least laterally. But when you go in to debride it, do not debride the regenerate bone, leave it alone. Just I&D, wash it out. Don't remove tissue unless it's frankly necrotic. Okay? I&D it, close it over a drain. So we incise and drain. We don't put Vax on. We don't do any of this. We put a drain inside and we hit them hard with specific antibiotics that they're sensitive to. And we suppress it. So chemotherapy. And then we continue lengthening. Okay? And we complete the lengthening. Once we complete the lengthening, we take them back to surgery. The regenerate's not healed yet. We put on a temporary X-fix in the femur. We do it anteriorly. Okay? Actually, in the tibia, we do it anteriorly too. So, anteriorly. 2 pins, 2 pins. Usually in the calcar region, medial to the nail. Okay? Put on a lock like an orthofix or some simple X-fix. Just lock it. One that doesn't have ability to bend. Just rigid and X-fix. And then, don't put a TSF, it gets in your way. Okay? And then, we remove the previous nail, ream the canal only a little, maybe 1 or 2 millimeters above what was there before. Wash out the canal and put a static trauma nail locked proximally and distally. We do not bone graft, even if they need it. It's still infected. You haven't sterilized it. Take off the external fixator, it's just an instrument, and allow the patient time to heal the regenerate. If they're not healing the regenerate, then 3 months, this is not a regular nail. This is an antibiotic coated nail. One of 2 ways of coating the nail. The classic way that we published 2001, where you basically make a mold with a plastic tube. We used to use chest tubes. Now we go to the hardware store and buy these, I don't know, they're silicone tubes or something, these plastic tubes, and we sterilize them. And they're heat resistant, so they don't melt. And we inject antibiotic-coated cement, regular locking nail. I don't even drill out the holes. You can see through the holes and you ream through them at the time of surgery, okay? And that elutes high concentration antibiotics, sterilizes the canal, kills everything. So that's what we do to sterilize the canal. Then 3 months later, I'll come back if they need, it gives them enough time to regenerate, and I will bone graft the site if needed. Most of them don't need it, okay? And if I want, I can remove at that point and put a nail without cement. The other way, which is a little bit more recent, is to inject an absorbable cement, which is basically calcium sulfate, which is plaster of Paris. But don't just take your regular plaster of Paris. So we use a commercially available one, that way we can pay more for plaster of Paris, called Stimulan, and we fill it with antibiotics, and we inject that in the canal, and then put the nail into the liquid of the canal, and it coats itself. So the advantage of that, it goes out the locking holes. So you get a little bit better coverage, and it's just as good. And it's resorbable, so you don't need to remove the nail with the cement. Because cement, if you leave it after all the antibiotics leaves, is a perfect place for bacteria to grow, because it's porous. So that's why you tend to remove it 3 months later. So that's what we did in this girl. And we had to come back, and you can see there's a trauma nail, and we had to come back and put in a recon nail there because it was proximal osteotomy, and she healed. She didn't heal, sorry. And then we came back and then bone grafted it, which you can see the bone graft here, from the iliac crest, and got her to heal. So that's our protocol. I think it's important not to become afraid of this, to recognize this. I think it's extremely important to inform your patients of their risk. And I have patients who've looked at this risk and said, you know what, my first X-fix lengthening was fine. I appreciate you telling me that I'm in a high-risk group. I would rather have another X-fix lengthening and all its related complications than risk this infection. And, and I say, fine, it's your choice. The majority accept the risk, but they are given an honest information about this. Before I knew about the antibiotic reducing the incidence, I was telling them that we had a 10% incidence. As I said, overall it was 10%, but it turns out it was actually as high as 16% before I used the antibiotic prophylaxis, and it's down, as I said, to 6% without it, which once you get it down to 6%, the patients say, I'm willing to take a 6% risk. Yes, Rob?
When I became aware of this information, what I've done on a couple of cases, and it's worked so far anecdotally, is done injected the
Stimulant.
Together with the lengthening camp.
Yeah, how's that been for you?
It's been okay.
Is there any bone healing issues?
No.
So it doesn't,
I just most recently did it where I was compressing, and it doesn't seem to bind up the nail. So
and it doesn't, because with the drill holes, it squirts out the the osteotomy site. Does it cause any healing issues there? No. Yeah, we've contemplated that, and we've done it once, but it's the logical next step, because rather than just give systemic antibiotics, if it's hypovascular in the canal, they're not going to get in there. And so this thing is really,
we use it's very dilute, so we use several packs of stimulant, put a lot more water, and put it in a 2-meter syringe, and just do a
Right.
squirt and shove it out.
yeah, no, I
Joe Shu mentioned it once, and he sort of sparked the idea for me. So
yeah, we thought of this a long time ago, but felt it's going to gum up the works, it's this. And then I think I heard Janet had done this also at your place, and we did one, and it went fine. So I may do that in the future. I think it's a good idea.